Okay, right. So the theory of MS Diagnostics, what we benefit from, because we want to be at lunch on time, right, is that we already have now previous knowledge, which means that our slides go through faster. And this is, in fact, a talk about how I diagnose MS and what I look at. So I open a scan, and the question is, for example, disease activity, or is it MS or something else? And I will give you a tour on how we as neuroradiologists look at this. So you learned in the last lecture what MRI sequences are useful, and now I give you the clinical tour on how to diagnose MS radiologically, and also what is valuable for related conditions which might not be MS in the classic sense. As you can see on this overview here, as a radiologist, I either have to prove that something is MS, which is for radiologists very difficult. I can only tell that something looks like MS on the MRI, but in fact the clinical diagnosis is a bit more complex, and or I can also exclude other diagnoses. And in both cases, MRI is a crucial part. However, bear in mind that there are new diagnostic criteria just coming, and I think they'll be published in the summer, and the manuscript is already in writing. So currently still, what I have to show, if I want to prove that someone has a MS, which I can't as a radiologist completely, is that there's a dissemination of lesions in space and in time, which means they have to be at certain MS typical places, and they have to show a timely progression. Or active or non-active lesions next to each other. In this year, there will be a new typical location coming up that you can already remember, and that is the optic nerve. So until now, the optic nerve, even though a lot of patients had optic neuritis, so an inflammation of the optic nerve, had a mass. It wasn't a typical lesion, but now this will change. And also, from now on, dissemination and time is no longer always necessary. In some cases, you can say that that dissemination in space is sufficient. Until now, this older paper is still valid from 2017, as I understand, and will be replaced this summer by the follow-up paper coming up. Yes, please.
Dissemination in time doesn't mean recall, does mean you have
new lesions. New lesions that I see at a later time point, or active and non-active lesions next to each other.
Okay.
Yeah,
okay.
Yeah, but you'll see soon. So let's start with our brain again. So what helps us is to find, for dissemination in space, or DIS, at least one lesion in at least two typical positions. Yeah, so 2 lesions in total can give you the dissemination in space if they are located in the good places, and you need 2 places at least. And the places that we mainly look at, and that most MS patients has, is periventricular. So those are lesions that are mainly perpendicularly towards the ventricles, anywhere at the ventricles, in fact. Then you have, this is a typical view with Dawson's fingers that give you a typical view close to the corpus callosum, where the lesions are perpendicular to the extension of the ventricular system, called Dawson's fingers because they go out of the ventricular system like this. And then you also have juxta or intracortical lesions. And a juxta or intracortical lesion is a lesion that you can, for example, see here. So this is the cortex, and this is our lesion. And this lesion is like really snuggling next to the cortex. Yeah, it's not like the ventricular lesions.
Recording stopped.
Indeed. Okay.
Recording in progress.
So it's parallel to the cortex, and very important, there's no space between the cortex and the white matter. So as soon as I can see a space, it's by definition no longer a juxtacortical lesion. So it must have direct contact to the gray matter, or be inside the gray matter. Here there's a second lesion that you hardly can see. And then we have our infratentorial lesions, and the infratentorial lesions, unlike in this case, are very often in the periphery of the brainstem or the cerebellum, so very close to the CSF spaces. And yeah, so not like those. And very often they also touch the trigeminal or facial nerve. So what you can see is that the lesion extends into the cranial nerves. So that explains also why a lot of MS patients have cranial nerve issues. For example, trigeminal pain. Yeah. And finally, bear in mind that the optic nerve is coming up also as a fifth lesion. And those optic nerve lesions are a lot more difficult to diagnose if you do not have orbiter sequences. That's also a problem. So for the orbit, we classically want very thin, 2 or 3 millimeter thick coronal images that in STEER or, I don't know, Dixon sequences, but show us the optic nerve nicely. Very often we only have 3D FLAIR, and there's just no real fat suppression, and you have a lot more artifacts in the orbit. So it's more difficult to identify optic nerve lesions. And what you have to learn there is that an inflamed optic nerve is brighter than the white matter. See here, it more looks like gray matter, but it should look like white matter because it's in fact, it's a fiber tract, so it must be like white matter. And this is what inflammation looks like. And in MS, those lesions can be very small. Like on the left image, it's only part of the optic nerve. And also the location is very important. Right, contrast enhancement. This is the same patient as previously. And you see here that the juxtacortical lesion is contrast enhancement. Contrast enhancement is important in the diagnostic workup of a new patient, for example, because you can possibly faster diagnose MS than you could if you didn't give any contrast, because you will then see active lesions next to non-active lesions, and by that you have by definition you have a dissemination in time, because active and non-active exist parallelly. What you can see with the contrast enhancement is that the lesions have different shape regarding contrast enhancement. So they can be nodular, like here on the left hemisphere on the picture. You just have a spot, which of course raises issues in some patients. Is this MS or is this something else? Or they can have a typical open ring structure, which is something that is not classically seen here on the juxtacortical image, but it looks like a ring, but it's just open on one side. And then it can also show you like tumor-like issues we'll see after lunch. And for the optic nerve, it gets more complex again. If you have post-contrast optic nerve images, you have to make sure if something is inside the optic nerve, which would be MS typical, or if it's more paraneuritis, which would speak a little bit against MS.
Vera, where is the lesion in the optic nerve? I cannot really see.
Yeah,
is
so
it black spot?
so this one here, this thickening here is in fact paraneuritis. So this is like around the optic nerve. Yeah.
Okay.
And here it's much smaller inside the optic nerve. So this is optic nerve and post-contrast is very difficult. There, first of all, the sequences often do not have the quality that you would expect. And secondly, there's a lot of debate where my colleagues and I are doing a study on a related disease, not MS, but a MOGAD study we'll talk about later. And there's hardly ever consensus in the study regarding optic nerve enhancement. And people are, I don't know, 2 radiologists, 4 opinions. So, again here. Right, contrast agent Wentu. I would like to draw your attention to some publications that came up more or less recently. So first of all, the official guidelines from 2021 tell you about when to use contrast in patients. And that's, of course, for example, for new diagnostics, but also in certain follow-up situations. And where contrast is also very valuable is in patients that have loads of lesions. So say your patient shows clinical disease activity, but you know the patient has like trillions of lesions, then the radiologist will have a very hard time to find a new lesion. And to increase his chances, you give contrast, even though you strictly, it would be enough to just see the new lesion, but because you know that the radiologist will fail in this job, you give contrast to help him a little. Contrast agent, of course, gets injected, and in fact, the tolerance for gadolinium post-contrast is very good. So the toxicity is very low and allergies are very low. You cannot give it during pregnancy, or at least you have to warn the woman that it's not good for her baby. Yep.
Sorry for the question.
Yeah.
That if the motivation for contrast agent is mainly that you can just not deal with the vast number of lesions, do you use any processing software to? I mean, it could be software processing.
Yeah, there are many like computer-assisted softwares, devices for automatic detection. Some of them are reasonable, some are not reasonable. Do we use them in Amsterdam? Currently not yet. Will it come? For sure. But the number of people using CE label, because they have to be CE label, so they have to be allowed for medical clinical use, this is very low. And so I think the prices are pretty costly. I mean, of course, in an experimental setup without CE labeling, there's a lot more use of that, but in the clinical context, only very few centers use this.
So currently solutions missing.
Yeah.
First point. Secondly, might be expensive, while of course another sequence is also expensive.
Yeah.
So it's return of invest quite easily. I don't know, but But you would expect there are changes.
Yeah, definitely. Currently, on the medicinal product market, there's also the issue of who pays for it. I mean, we get paid for MRI scans, not for AI-based softwares. So we have no financing for this. You know, this is something that would have to change first. Right. Yeah, and of course, contrast is sometimes helpful to find differentials of MS, because if something pops up, and as you'll show later, and it looks like infection, then you're helped very much. Regarding the new 2025 criteria, SWI, as I just said, has more, will have more value. For example, regarding the central vein sign, that will help you diagnose MS lesions and differentiate it from other lesions. But also there are so-called paramagnetic rim lesions. So this is again the central vein sign. And the paramagnetic rim, as may be seen here, for example, yeah, this is something that could indicate current ongoing inflammation. And for example, you have those two lesions here, but only one has a paramagnetic rim. This can stand for a chronic activity versus a non-active lesion. In the spinal cord, we can just keep it very short. In MS, what I'm looking for is short lesions. So MS lesions are relatively short and less extensive compared to its differentials. Very often there are multiple lesions, and very often they do not cover the entire segment, but you'll see later, at a later stage, what I mean by that. And of course, the same as in the brain, we have to differentiate active from non-active lesions. And I must say that contrast agent is more helpful in the spine than it is in the brain, just because the lesions are so small. Very often you have confluent lesions, so lesions that just add up into each other, and then for me it's extremely difficult to find the active lesion in such a conundrum. Yeah, bear in mind that there are typical locations for MS lesions, and those are at the periphery in the white matter. Remember when we cut through the spinal cord as assassins, the white matter was outside and the gray matter was inside. So because MS is mainly a white matter disease, you find the lesions in the periphery. But in fact, they can be in the gray matter too, as Eva already pointed out. So there can be gray matter lesions found, and that does not exclude MS at all. Here is a typical example. This is what those lesions look like. You have a relatively high quality scan. You can even see the butterfly here. That time the patient is lying on his back, so those are the anterior horns or the posterior horns. And the lesions are typically in the periphery of the spinal cord and not centrally in the gray matter or just touching it. Integrating radiological diagnosis, I tried to sum it up, but as you can see here, like MRI is like a central pillar of diagnosis. Of course, you also have CSF based diagnostic where you can find certain protein in the CSF. I think you'll talk about it later. Yeah, so I will not say too much about it. And of course, the clinics are also very relevant. But MS is almost always part of the diagnostic path. If you don't find any lesions, then of course it's very difficult to establish a case. Yeah, it's like in a lawsuit. Yeah, it's just if you
not possible anymore.
Yeah.
No, I think in the next diagnostic criteria there will be a statement that is that MRI is necessary.
Yeah. So yeah,
to
if you
diagnose MS.
MRI is in fact the witness. Yeah, and no witness, no case. Yeah. So and depending on how strong the indications are, you need. According to the news guidelines that will just pop up in 2025, more or less lesions and more or less dissemination to be shown to construct a case that you can establish the MS diagnosis. And this is a bit complicated. I wrote it up for people who want to have the PDF later, but I will not go into detail here. But bear in mind that certain combinations of MRI features trigger different diagnostic certainties in combinations with clinics and CSF. In summary, MRI is one but very important pillar of MS diagnostics. So everyone who has a suspicion of MS will get an MRI scan for sure. And it's also a core pillar of follow-up of the patients. This is something we also have to talk about. But patients, of course, get their yearly MRI scan or their clinically triggered MRI scans out their regular scheme. And without MRI, you cannot do this with a CT scan, and you can also not do it without imaging. So our MS patients know the radiology department really, really well. And they're very... how do you say this? They're very adherent patients. So they are patients who usually have a low percentage of no-show. They for sure will come. You will see them every year, very often on the same day again for their follow-up. And they're very routine patients and very well-informed patients very often. Content-wise, regarding MS diagnostics, bear in mind we have 4 classical locations of MRI locations to diagnose MS. Do you still remember them? What were they? Periventricular, yeah, with the Dawson's fingers. Juxtacortical and intracortical. Spinal cord. And, sorry?
Optic nerve.
Optic nerve will come up as the 5th one. Officially it's not yet. And infratentorial. Okay, so here the master question. Say you have an infratentorial juxtacortical cerebellar lesion. So the cerebellum, of course, has its own cortex, and you have a juxtacortical lesion at the cerebellum. Then it's both juxtacortical and infratentorial. Does this count as 2 locations?
Does it? Yes.
No. So sorry, but this combi deal is not allowed.
Why not? What's the question?
Yeah, this is a good question. So I'm not one of the people who radiologically sit on advisory boards for diagnostic criteria. Like I've colleagues like Frederick Barkhoff or Mike Gottjes, and I don't know why they opted against this, but it took me a while to find out, and several emails, but you do not have this double thing. So you have to categorize it either in category 1 or 2, but then you still need this other one. Yeah.
Not the answer to the question why.
Yeah, that's true. But well, I said I don't know, right? So yeah, yeah. So I cannot.
It's because MS is per definition a disseminated disease.
Yeah.
So it's per definition a disease that it's chronic, meaning that there is multiple events and that it's multifocal in the terms of different parts.
Okay.
So if you only have infratentorial or cerebellar juxtacortical lesions, there is no spread, and the chances of another alternate diagnosis are too high, and also the prognostic determinations are not valid. So
Okay.
yeah.
But usually these studies are like that they have mimics and they see if you don't do that,
Yeah.
there's too much false positives or
Yeah.
negatives.
Yeah, so all the MS studies is, does it reliably distinguish alternate diagnosis, and can we predict subsequent disease activity, of course, for treatment decisions.
That
So,
means it's not
yeah.
usually, these decisions are not necessarily driven by a pathological construct, but the results of these comparative studies.
Yeah.
So then afterwards you have to think, why is this the case, and we don't know.
Yeah. So I must say, just from the amount of MRI scans, you'll be surprised how different two MRI scans of MS patients both have MS, and you would not guess that they both have MS, because those lesions you have patients with a lot of nodular punctate lesions, and you read in your manual you have to look for ovoid lesions. Yeah, ovoid lesions with a central vein sign, and then this patient only has punctate lesions more or less, so not the classic shape. Okay, what do I do with it? You have patients who have predominantly juxtacortical lesions, but hardly any paraventricular lesions, or only paraventricular lesions, yeah, or patients who have only supratentorial lesions, but not a single spinal cord lesion and not a single infratentorial lesions, and somehow you have to deal with this. So they all have the same diagnosis, but they just do not look very similar. So the diagnostic criteria, so the more diversity you see in the scan, the surer you can be of a diagnosis. And sometimes you have those patients. Yeah. So contrast administration helps you in the dissemination of time and helps you especially in cases with a lot of lesion load. So sometimes I'm not so happy that a patient didn't get any contrast, because I already know that 60% of the white matter are in fact sclerotic plaques, just forming a forest of sclerosis, and please try to find the active lesion in there. Yeah, this is something that we cannot do as humans. And bear also in mind technically that SWI seems to be on the run here. So this may have a chance through the new recommendations coming up this summer to be added, at least for some patients, when, for example, the paramagnetic rim sign gets more importance, and also the central vein sign to differentiate MS lesions.